Hello, I am Ridiko, and I will be having a parasitology lecture with you today. And I will be talking to you about Giardiasis and Trichomoniasis, which is, these two are parasites, parasitic infections caused by protozoans that are unicellular. And for you to get an idea of where these parasites exist within the spectrum of other parasites, I will show you a flow chart to just give you an idea of where these ones are. And these are flagellates. So here you will be able to see that, So these are the protozoans, they belong into the protozoans. And the ones that we'll be interested into are here, there, under the flagellates category of these parasites. Great. So before we start, I'd like to start with the history of a presenting illness. It's a vignette. So your cousin visits your home after an early release from Segerea prison, and you go to visit the toilet after he has gone to relieve himself, and you're bombarded with an awfully bad smell. And he confides to you, I mean, since you are in Mwimbili student, that he has been experiencing diarrhea, and that is very foul-smelling multiple times each day, accompanied with nausea and gas, flatulence. He reports that when the diarrhea started, it was much worse than what he's facing now, although it has subsided, but the diarrhea is still persistent. He does not report to have any fever or any other symptoms. And while he's telling you prison stories, he complains that the hygiene in the toilets there is horrible. And there are times where he don't have water to wash after going to the toilet. And he reports that he notices that his stool is very, very sticky and sometimes floats when he poops in a body of water. However, there is no blood in the stool. So I'd like you to think about this cousin and remember these symptoms as we're going to come again to discuss what could be ailing him. So Giardiasis, as I mentioned, this is an intestinal protozoa, and it was discovered in the 1680s by Antoinette, the guy who invented the handheld microscope. And he discovered it while he was looking under his own stool, and he found the Giardia parasite there. So they usually reside in the upper part of the small intestine, the duodenum and the upper jejunum. So just for your memory of anatomy, this is where the duodenum and the upper part of the jejunum is located. So this is, as I said, is a flagellate. It has existence in two forms: a trophozoite form, which is a trophic phase, where these parasites are eating. So tropho is also associated with eating. So these are associated in the small intestines and are usually found in diarrheic stools. So during diarrhea, you're more likely to find trophozoites of Giardia. And the cysts, these are the infective forms. These are usually found in the lower bowel and or more better formed stools. And these are more persistent in terms of survival outside the human body. And this is how they can be infected. They can even withstand sometimes chlorination of water. So this is the life cycle of Giardia Lamblia. There are several reservoir hosts, but the beauty of this organism, it does not have intermediate hosts. It's just from, the only host is the immediate is the environment. So you would get cysts. You can get cysts which are quadrinucleate cysts. They have 4 nuclei. When you eat these cysts, they get into the stomach, and then at the duodenum, the cyst comes out, and they form. One cyst gives you 2 trophozoites. So of the 4 nuclei, you would have 2 of these trophozoites, and these trophozoites immediately start to invade the columnar epithelium of the lumen in the villi, and then they attack them. They conflict. They keep dividing, covering all these villi, and you will understand this slightly later when I talk about the pathology of this. But they flatten the villi, and then after some time, these trophozoites insist in the small intestine and get out as a cyst again, and the cycle continue where they're picked up during transmission in human. So the trophozoites are, half pear-shaped. They look like teardrops, and the size is 12 to 18 micrometers in length and 5 to 15 micrometers in width. This size is very relevant, especially when you're talking about the magnification of these parasites, if you want to look at them under a microscope. And the ventral surface is usually concave, sucking disc-shaped, so that they're able to attach on the villi. And they usually release a compound called Giardia, which is usually the one that helps them to attach and suck the villi. And it has two ovonuclei, which are within the sucking disc. At the posterior end, they have flagella, two flagella, but they have total 4 pairs of flagella. And then they have axostyles. Axostyles, these are microtubules that are stiff, but they help into the mobility of this parasite. And they have parabasal bodies, which are created in the median, and they reproduce by binary fission. They split in half, they keep on going. So this is how it looks like, the trophozoite. It has a adhesive disc. This is a sucking disc, and these two, they look like eyes, but these are kinetoplasts inside the nucleus, and these are the pairs of flagella. So this is another microscope view of this Giardia lamblia. They look like they're looking at you. And these are the trophozoites. They look like teardrops or pear-shaped. And these is another, electron microscope view of this Giardia. There are so many of them attached on a wall of intestines, duodenum and jejunum. And this is going to be relevant when you're talking about the pathology of the parasite. The cysts, these are oval-shaped, smaller, and they have 4 nuclei, as I mentioned before, and they also have exostyles, and this is how it looks like. And you would find them mostly in foam stools. And they are the distribution, so they're widely distributed. Everywhere in the world you could find giardiasis. And the high prevalence, especially in developing countries where, which is warmer. In temperate countries is slightly less common. So in a man is usually the source of infection. Animals like beavers and things like that could be reservoirs, like dogs and muskrats, when they can be reservoir of infection. But the source of infection is usually children, especially in homes and in kindergartens. The transmission is usually by ingestion of viable cysts. So there are different forms of epidemiology. It could be found in endemic setting, where they're usually found in an everyday problem in the families, or you could have children under 3 years old are usually most affected in endemic setting. You need to take note of this. And these are usually in fecal-oral route, especially in poor hygienic conditions, but they're related to poor personal hygiene, poverty, and poor sanitation. These are places where you would have these parasites existing in an endemic context. But in sporadic context, where one cases, this is also known as a traveler's diarrhea, acquired mostly by travelers, also nicknamed beaver fever, because the beavers are also known as the hosts for this parasite. And there could be an epidemic as an outbreak. So it could happen in places where there's disease is not normally happening, but it could be infected in municipal water supplies, in fecal institutions, in places like people who are mentally retarded, prisons, children's homes, which are poorly taken care of. So these are the 3 forms. Could be epidemic, endemic, or it could be a sporadic kind of epidemiology. The transmission, as I mentioned, is with fecal-oral, from feces to the mouth. So you've eaten feces, basically, or it's foodborne, or it's waterborne kind of context. So in fecal-oral, which is intimate contact with infected individuals, like family young children, as I mentioned, male in homosexual populations. You would know why homosexuals are, and usual route in endemic tropical areas. As again, the family infection is a route. Foodborne, these are usually vegetables that are contaminated with human excreta in vegetable gardens or food handlers in the markets. You may have seen recently the reports that sugarcane juice in Bugando is contaminated, is fecal contaminated. There are publications that have shown that. So these kind of could be sources of these parasitic transmissions. It could be waterborne, as I mentioned, which are contaminated water sources. So the pathology. So susceptibility, it is increased by people who have, let's say, aclohydria. Aclohydria is a lack of or very, very highly reduced hydrochloric acid formation in the gastric. And people who have this problem have a tendency to have increased susceptibility to the disease. The literature is still debating, but there is evidence that people with blood group A or children with blood group A have more susceptibility to this disease. Some literature says there's no evidence per se, but this is an ongoing debate. People with protein energy malnutrition obviously puts you to be susceptible and have any other lack of IgA. So just for you to understand why lack of IgA is important. So when these parasites get to invade and attach to the villi, to the suckers and the villi of the GI system, they secrete the Giardian compound, and your body starts to fight this infection in one way or the other. And this secretory IgA tends to counteract the effect of this Giardian in such a way that when the immune system mounts high enough, that's when there's a shed off, and then they start going into the lower part of the bowel, and then they usually disintegrate and disappear there. So this means you can have a self-limiting kind of an infection without having to use any medication, and it could disappear on its own. But again, when you have the infection, it's usually a problem. But if you have immunodeficiency, this is where you could have problems of chronic type of Giardiasis, where you would have consistent problems with the diarrhea. So trophozoites are found in mucus, adherent to the mucous membrane, that are touched by the sucking disc. But invasion into the mucus is rare. And this is an important fact, especially when you have parasites that do not invade the mucus or beyond the mucosal invasion being rare. That means there is very low chance of you having a blood in the stool. So this is another important fact for you to know when it comes to the pathology. So clinical manifestations, they could be due to interference with the functions of enterocytes, right? So there's a decreased level of absorption of disaccharides. And this is because of the blunting of the villi. As you've seen in the previous image I've shown you, they tend to blunt the villi, and the absorption becomes much, much lower. And in some patients, the severity of the changes, they also correlate with the severity of the symptoms. And then you get things like malabsorption symptoms, and the presence of antibodies that are circulating, they become damaged. So these malabsorption become malabsorption syndromes, and you're not able to absorb a lot of nutrients, and then you start to pass fatty stools, which is known as steatorrhea, and this is where the foul-smelling stools come from. So another potential explanation of how Giardia causes malabsorption, one could be a mechanical interference with the gut absorption, as I mentioned, but also sometimes because of the presence of this foreign body, it will lead to a host inflammatory response and cause damage to the villi because of the inflammatory response, and not just the presence of the parasite itself, but also the trophozoite invasion in terms of the presence of the toxins that could be presented, although this would be rare. But also sometimes could have a bacterial overgrowth because of the coverage of the villi. But also it could be uptake of deconjugated bile salts. So this is another thing. If you know, the duodenum is quite important place when it comes to biles. So this is another image, as I said, electron microscope. This is an important part for you to see because if you would see, this is let me change, sorry, for you to get a better view. This would be the sucker, the sucking disc that is covering the villi, right? And these are the villi that's going to be damaged, and then this is where they would prevent absorption, and this is the sucking disc itself. So moving forward, immunity also plays a role in this. So it's a common disease in endemic areas. Children will be affected in early childhood. Usually the first infection is symptomatic, but subsequent infection could be asymptomatic. Visitors tend to in endemic areas are also symptomatic. Older children and adults rarely develop symptomatic infections, but they would also, because of the immunity development. So 20% of the infections are usually symptomatic. Acute diarrhea illnesses that subsides within 1 or 2 weeks, bloating, flatulence, upper GI cramps, nausea, malaise, low-grade fever sometimes you could have, or even no fever. Watery, greasy, foul stools is common, and there's no blood or leukocytes that's present. And some patients can develop chronic diarrhea, but symptoms and passage of cysts usually do not persist more than 3 months. So immunodeficient patients may have chronic malabsorptive diarrhea, malaise, lassitude, headaches, weight loss. These are patients who are immunodeficient. Less than 10% of the cases usually develop clinical malabsorption and weight loss. But this is very bad, especially in children. They could lead to malabsorption syndrome, and children could get failure to thrive and have problems in growth. So usually diarrhea is the main symptom, and it's usually explosive with pale stools, and usually people can get weakness, can have dyspepsia because of indigestion, and the malabsorption of this disease can lead to lack of vitamin B12, and folate will be common. And if you look at the full blood picture of these patients, they could have megaloplastic type of anemia because of lack of vitamin B12 and folate. So in advanced cases, you could have huge problems, especially when you have fatty stools, weight loss, and lassitude. And differential diagnosis could be, other small bowel diarrheas, it could be duodenal ulcers, you could have gallbladder disease, it could be malabsorption due to other parasitic diseases such as tropical sprue. So back to our cousin. So this cousin, just for you to note, there are a few things that are important for you to note. There is bad smell, awfully bad smell. And this patient has been experiencing this diarrhea multiple times a day. There is nausea, which is a non-specific symptom of gas, but also this diarrhea is now becoming chronic, although it has subsided, but it's still persistent. And there's usually no any other symptoms, and there's a history of poor hygiene in the toilets, and also the toilets, the stool that is presenting as sticky and sometimes floats when it poops. So this could be a case of Giardiasis, and one of the things that might be not telling for this patient is if this patient is long-standing in a tropical, in an endemic environment or non-endemic environment, it will be something to take note of. It'd be much more telling, especially if this cousin is a visitor from a place where they're not usually have this disease, and it becomes a sporadic case. But this is how you would be finding patients, and you have to think through. So how are you going to diagnose this patient, whether it is actually Giardiasis or not? So there's one is demonstration of trophozoite samples from stool examination. And it's not always positive stool examination for trophozoites. As I mentioned, usually diarrhea samples are there. So you can take up to 3 separate examination to get to see whether you can find this trophozoite there. And this is because these trophozoites are stuck and sticking over the walls. So it becomes slightly difficult to dislodge. So sometimes it becomes positive, sometimes it doesn't. And so it's important to do up to 3 examinations when you're doing on separate days to recover trophozoites. Again, trophozoites, not cysts. And then another mechanism is duodenal drainage, also known as a string test. So this is where someone it takes a string that is in a capsule, a gelatin capsule, and you swallow it, and it stays in your duodenum for, and you put a tape here on the side so that you don't swallow the entire string, and it stays for about 2 hours, and then afterwards you pull it out, something like this. And then when you pull it out, you get to shake off and then to make mechanical shaking so that you could see the trophozoites that are being restored from the mucosa membrane of the duodenum, right? So this is another. So you could do this in microscopic examination. So also you could do duodenal biopsy and you could examine the mucosa smear of the biopsy. This ones could easily be, the pathologist would easily identify this. But also the immunodiagnostic tests, which include fluorescent antibody tests. You could do ELISA detection of Giardia specific antigen, and there are also even rapid diagnostic tests, tools to detect Giardia specific antigen, which are quite sensitive. And how do you treat? So if you do this to this cousin and you find that they are actually having Giardiasis, either by microscopy, by examining stools to see cysts, or to see trophozoites, or you've done all your tests, the drug of choice is usually metronidazole. You could do a large single dose of 2 grams daily for 3 days, or 2 grams daily to be followed by second dose a week later. Or you could do for children is usually 15 milligrams per kilogram per day. You can also use tinidazoles or paramomycin. These are also used, especially useful when a woman is pregnant, because they tend to paramomycin tends to remain mostly within the lumen. This metronidazole and tinidazole are it's quite important to mention that you shouldn't use alcohol when you're using metronidazole, because it tends to create some form of a disulfiram effect, which is not good. You might have learned this in your biochemistry. It's not good for your health. You might get nausea, vomiting, and it's quite bad. So in the control and prevention, there's treatment of water. As I mentioned, the chlorine might not work as much, so there's super chlorination of drinking water. Also combining chlorination and filtration methods, and also boiling drinking water also helps. Preventing contamination of water supplies, proper excreta disposal, making sure there's good personal hygiene, wash your hands before and after going to the toilet. Health education also is important when it comes to controlling these diseases. Yeah, so that is what I wanted to share with you with regards to Giardiasis. And if you have any questions, this is the time. We can take 2 minutes break before we go to the next version of the presentation, which is the trichomonas vaginalis.